My name is Ilse Jonkers. I'm from KU Leuven in Belgium, and I'm very honored that I can introduce to you the keynote of Thor Besier. Thor is an associated professor at the Auckland Bioengineering Institute, and he also has a joint appointment with the Department of Engineering Science. He completed his PhD in Musculoskeletal Biomechanics at the University of Western Australia in 2000, and he was a postdoctoral fellow in the bioengineering department at Stanford University from 2003 till 2006, and that was where we first met in our academic careers. Thor's current research that he will be talking about today combines medical imaging with computational modeling to understand mechanisms of musculoskeletal injury and disease. Therefore, he has been the driving force in pushing forward the development of open source modeling tools to rapidly generate musculoskeletal models that can be used to diagnose and treat injury and disease. He also was one of the driving forces of the Grand Challenge dataset, and that is now the reference dataset for knee model validation for the biomechanist community. It's without say that Thor has an excellent publication and funding record, and that he draws from all major funding mechanisms worldwide. But more importantly, I always appreciated Thor as an inspirational colleague, aiming to do rock-solid research and with a strong ambition to really make a difference to patients. I'm sure that you will be able to appreciate his drive and motivation in the upcoming presentation that he titled Personalisation of Biomechanical Models to Understand Joint Degeneration. Thor, the floor is yours. You should have brought your sunglasses.
Thank you, Ilse. Thank you very much, first of all, for inviting me here, and also to the organising committee. And it's kind of nice to say it's good to be back in Calgary. I was here for the ISB in 1999, and I have to say, yes, that was 20 years ago. I can't believe it's been so long ago and gone so quickly. And also, I was here for the World Congress in 2000, so it's really nice to be back in Calgary. Today I wanted to give you a bit of a flavour and an overview of some of the work we've been doing, some of the groups that I collaborate closely, some of the work that they've been doing, and kind of give this overview that also leads into the other talks that Ilse's organised this morning, because there's people that are going to be up here after me showing some quite sophisticated computational models. So my talk's really a bit of an overview of the field and really a bit of a vision for what I think might happen in the space of personalised medicine. Okay, so there's kind of three components to what I'll talk about. First of all, the need for personalised biomechanical modelling. I'll talk a little bit about the challenges that I see in taking these models into the clinic, because ultimately what we want to do is influence clinical translation. And thirdly, I'll provide a framework and an idea for how we can actually take this forward and look at personalised biomechanical modelling. So first of all, I think it's really important to state that there are multiple pathways to osteoarthritis. I mean, everybody in the room is aware of this, but I think it's important to state it up front. And as early as 1939, it was acknowledged that functional stimulus of some description can change the physiological environment of this tissue, and it can do so with deleterious effect. And so for the past decades, of course, we've been trying to understand what is the mechanical environment of this tissue, because if we can understand this mechanical environment, perhaps we can do something about it in terms of preventing the onset progression of this disease. So this is two potential pathways to osteoarthritis. The one down the bottom here we see is an overuse or an impact, say, trauma. So here we have a large instantaneous load that leads to cell death, which is what these little red crosses are. And then following that, there's a cascade of events which results in degeneration of the tissue. And another potential mechanism that I've put here is one of underuse. And so here, the loading environment has changed and potentially reduced to the point that the chondrocytes are not experiencing the loads they should be experiencing, and that also could lead to deleterious effects in the tissue. So here we have this bit of a quandary, because on one hand, we know that cartilage needs to be loaded, but we also know that too much load or too little load is deleterious to the tissue. So we know mechanical factors influence the onset, the progression, and the severity of the disease, and potentially then altering the mechanical state can provide us with an opportunity of changing this pathway. So our first challenge is to understand or address this idea of whether we can determine if someone has early onset of degeneration, because if someone comes to us in the clinic and they have sore knees and radiographically the cartilage is completely gone, there's very little we can do. And in fact, there is no cure for osteoarthritis. End-stage osteoarthritis, of course, results in joint replacement, and we know there's a big rise in the need for joint replacement. So we want to attack this early, of course. We want to have early identification of OA so that we can design an early intervention. So this is the first challenge. Now, here is a rather simplified mechanical model of degeneration of the joint. Now, I say it's simplified, it might look confusing to you, but ultimately what we're interested in here is the degeneration of this tissue, which we think is related to its mechanical environment. So here we're talking about stresses and strains of this tissue. And the combined cycles of load lead to some sort of load exposure of this tissue. Now, this is where it gets more complicated. This is where we've invested a lot of time and effort, because to understand the stresses in the tissue in vivo, we need to understand the material properties of not only the cartilage but also the underlying bone. So together, they influence the stresses in the tissue. We need to understand the thickness of the cartilage, the contact forces, the contact area. And of course, this is where it gets even messier, because the contact forces, of course, are influenced by a myriad of parameters, and mostly the muscle forces. You know, muscle forces, and we know this from the Grand Knee Challenge, really drive the forces within our joints. And ultimately, this is another challenge, I think, in the biomechanics community for, again, a very long time, is focused on kind of this middle area here. More and more we're pushing down to this path to try and understand beyond here the cellular type of response of the tissue. But more and more, I think we also need to acknowledge that there is a brain and a central nervous system above all of this that's controlling the way we move. And so this is, gives us a framework and a place to start to try and investigate these various parameters. So there's a few take-home messages here. The first of which is that tissue mechanics is complex, and it involves a number of factors. The second thing is that medical imaging and experimentation can help. And medical imaging, as we'll see a little bit later in my talk, has the potential to really change our area of research. And it has been game-changing thus far to be able to image the tissues, not only in ex vivo, but also now potentially in vivo, to try and get those early identification or markers of joint degeneration. We have uncertainty in our parameters, and this is something, again, some people have started to tackle this problem. I'll talk a little bit about this, but it's important to acknowledge that we have uncertainty in parameters because we're dealing with models, and computational models have sometimes many parameters. And really, if we are to understand this problem and in a holistic sense and put all these things together, we need some sort of biomechanical model to bring all of these different factors together. Okay, it's kind of interesting to note also here that in the current state, if we look at published data in the literature and the factors that we think, different metrics that are important for the mechanical environment of the tissue, of course, we start to see some fairly gross factors here like body mass and general activity levels. There's been a lot of work, of course, looking at joint moments, going into a lab and measuring someone in a gait lab and looking at joint moments. And then it starts to get more challenging, okay, as we go down this pathway to potentially more the cellular level to understand cartilage in its native environment. And of course, as we do that, it becomes ever so more challenging to try and understand this relationship. So, current state of the art says, well, we're getting pretty well, again, thanks to the Grand Knee Challenge and BJ for putting this together, because up until then, we weren't quite so sure about how good we were at doing these net forces, but now we know we're getting better. But down to this area where really the rubber hits the road, consolidation and lubrication of the tissue, and then the cellular response. And this is where, of course, a lot of time and effort now, and we'll see in the coming years, people are really focusing to really understand this problem. So I think there are 3 challenges to clinical translation of personalised biomechanical modelling. The first of which is creating these models. And for anyone who's made these models, you know that this is a time-consuming process and it's difficult potentially to capture all of the parameters of interest. The second, of course, is validation and reproducibility, and we'll get to that in a moment. And the third, which is becoming very interesting, of course, with wearable sensors, is trying to measure things in the real world, because that's the context of which this tissue, of course, lives in. So patient-specific modelling, this is a typical workflow that we would have to get down to tissue level stresses and strains. So this is at a continuum level. We're not going beyond here for the purpose of this talk. But you, of course, need to represent the geometry and anatomy of an individual. You need to characterise the material properties of the tissue, understand something about the kinematics, and of course these are coupled, the kinematics and the muscle and joint forces, and have some representation then at a tissue level. And as I said before, this is time consuming and it's costly, and we're not quite ready to take these models into the clinic. And I'd like to think that in a few years' time that changes. Myself and many others in the room here are doing a lot of work to try and improve this. And a question that of course we need to ask, and those in the modelling community, is how specific do we need to be? What are the key parameters that we really need to capture here in order to get to the point of interest, being here tissue stresses and strains? So we keep that in the back of our minds. Now, if we're to influence our clinical colleagues, the first thing we need to do, and we should do this anyway, of course, is show that our models are reproducing something that we can measure in the real world. So experimentation here, of course, is critical. And this is difficult, and it's a challenge because not everybody has an instrumented knee. There were a few people, of course, who did have instrumented knees, and again, this is thanks to BJ Fregley, Daryl DeLima. I was fortunate enough to be involved in this, and these patients who have had instrumented implants have provided us, the general modelling community, the biomechanics community, with a really unique ability to test our models. And so for 6 years we held the Grand Knee Challenge. The data set's been downloaded now thousands of times. And we've been really fortunate to be part of this project and shown that this can really push the field forward. And it's really nice to see other people now starting to do this as well in terms of sharing their data. The other thing that's important is reproducibility. And all of us in the modelling community, I think, need to do a better job of ensuring that the models we develop can be used by others. And it's so common that we develop and design these models and they stay within our labs, and it's really hard for them to be given to other people to move on and use. But of course, this is the goal of science. What we want to do is build on top of what's been done before. We don't want to recreate models necessarily. So this is a new project. Again, I'm fortunate to be involved in this project. At Erdemir from the Cleveland Clinic is running this with a group of others. And we're looking then at reproducibility of models. So if you take the same data set, and this is focused on joint mechanics, knee joint mechanics here, if you take the same data set, some cadaver data, some instrumentation data, and you give that data set to 5 different groups around the world, what do those groups do with those data, and what are the results of those models? And so this will give us insight into the different things that we have to do in order to create our models and get to the answer of tissue level mechanics. And so hopefully from this project, and you can go into SimTK and have a look at that. Again, it's all open source. You can download the data. But hopefully from this, we'll again be pushing the field forward in terms of reproducibility of models. So just a take-home message here, I think sharing data and sharing models is absolutely necessary for our field to progress. And so I encourage people to do that and do that willingly. The third challenge I see is real-world measurement, and we've learnt so much by bringing people into the lab and doing experiments on individuals. But then, of course, those individuals walk outside and then they walk downstairs and across different terrain, and we have no idea what those individuals are doing. Some of those individuals go home and sit on the couch and watch the cricket final, which I'm sure many of you here were upset to learn that New Zealand lost in the final of the cricket. Other people might go on a run. I should be running, but I was too tired this morning. So understanding what we do in the real world is important because it gives us some sense of the total load exposure. Now, again, we can do this in the lab, that's fine, but how do we get outside the lab? And this is where wearable sensors come in, because we can now do some activity monitoring, and there's a bunch of people and a whole bunch of different companies who are doing this now as well, which is great. So we can potentially measure things in the real world. So this is now a feasible option for us, and I think it will take the field forward. The question I have, though, is how do you deal with these data? How do you integrate this information in the biomechanical models that you have? And so, we're going to spend just a little bit of time talking about some opportunities for how to make that. So this is what I think is a potential modeling framework of how we can use this information in the different biomechanical models that we've made so far. And ultimately our goal would be to be able to predict the degeneration of the tissue. So the patient comes into the clinic, we do some early markers potentially of joint health, and we can say to this individual, well, if you do these different activities, we could alter the time course potentially of this disease. That would be our end goal here. So we start off with, of course, understanding some geometry. This is what I've shown you before, going through to the point of trying to estimate what the individual stress strain environment is of the tissue for a whole bunch of different tasks. And then we go outside the real world and we try and estimate what some total load exposure is, and then do some predictions of and probability here of tissue failure. So how do we do this? Of course, geometry and material properties is a challenge. Several years ago, we started this project called the Musculoskeletal Atlas project, and the intent here was to enable people like myself to more rapidly create these computational models, because if you get a whole bunch of imaging data, people in the room who have done this will testify to this, it takes a long time to segment this data and generate really all the geometry. So we start off here with our standard motion capture markers that we collect in a gait laboratory. We have some medical images, potentially of the knee, potentially of other joints of interest. Here it's focused on the knee. And what we do is we have a population of statistical models that we've created from a previous data set. And we're quite fortunate to work with the Victorian Institute of Forensic Medicine in Melbourne, Australia, and they have a large database of CTs, and we have just a small subsample of that. We have 1,200 CTs in which we are segmenting and creating methods to automatically segment these CT images so we can create populations of bones. And some of my colleagues will be presenting some of the work. Julie Schwann, who's here, will talk to you about pediatric data sets, which we can get from this, and creating shape models in the pediatric world, because a lot of what we do, of course, is done on adult populations. But the nice thing about these statistical models is we can start to use very sparse data to predict quite accurately what the shape and geometry, and indeed sometimes what the material properties are of an individual. So what we do in this case is we take our motion capture markers and we then predict a set of bones that correspond to the motion capture markers using the constraints of our shape model. And this is nice because this prevents us, if anyone's done scaling in OpenSim before, this prevents us from ever getting the short femored, long tibiated person, because that person just does not exist. So we think this is a better way of scaling, and my PhD student, Duncan Baki, who's here, will also show you how we can improve the repeatability of our gait data by using this method. Next, we get on to segmenting the MR, and of course this is a challenge in itself, trying to segment out the geometry, but we're doing a pretty good job again of using shape models here. So we combine the shape models we get from we call this a global or a PCA fit. We change the modes, principal components of our shape model to best match these data. Then we can also modify that to best match these data. So we're merging the two data sets together and essentially then getting more accurate representation of the joint. Now finally, we can spit this out as an OpenSim model. We can also then add cartilage to the mix. And there will be another talk on this for a postdoc of mine, Marco Schneider, who's going to talk about how he can automate this process of getting MRs down to a reasonable finite element mesh. And ultimately what we want to do is have this completed in the time frame that would be reasonable to do this in a clinic. So we're talking less than 1 hour, ultimately. That would be our ideal case. But from that, then we can then add other soft tissue components, and this is some of the work we're doing with the reproducibility study, and do some joint mechanics study on models that have the same geometry. So we're addressing the problem here of this disconnect that's often the case between the rigid body models that we have in the lab to estimate loads and boundary conditions and the finite element models that we have that are really used for joint mechanics. So now at least we have the same geometry, and then we can do experiments that cross these two boundaries. So the next big challenge, and this is mostly done by the imaging community, and there's a lot of work to try and understand the mechanical properties of tissue in vivo. So this is some work actually that Katie Keenan did for her PhD back when I was at Stanford. And the question here, we were looking at the patella and trying to understand, the patella's nice because it's the thickest cartilage you see in the body, and we were taking plugs of these human patella and trying to understand if we can get correlate measures from medical imaging that would correspond to the constituents. And in this case, we're really interested in the GAG content, because we know that the glycosaminoglycans are responsible for withholding water in the tissue. They have a big part to play in the mechanical response of the tissue. So we thought, can we use functional imaging of MR to estimate what these contributions of GAG are? So we then have some imaging. We used, in this case, T1 row and T2 relaxation times to try and intuit the relationship between these imaging parameters and the GAG content. So we did biochemistry on these samples and then plotted some relationships. Now what I'm going to show you might be a little bit disturbing, especially for those of you who are in the imaging world who have done a lot of work in T1 row, T2 in particular. There's another scan called degeneration, which is out there, which involves a contrast agent to try and do the same thing. But these were the data that we got from 21 patella and multiple cores taken out of these patella, and we were trying to differentiate between the top part of the tissue and the bottom part of the tissue. And so for those of you who maybe can't read this at the back, what we're showing here is the T2 relaxation time in milliseconds across here, and this is the GAG content percentage wet weight. And the two lines that you see here are some regressions through the bottom part, which is this one here, and the top part of the cartilage. And I think most of you in the room will probably look at that and agree with me that there is not a strong relationship here. Unfortunately, the T2 relaxation times, at least that we saw here with these tissue specimens, were not strongly correlated with the GAG content. If we look at T1 row, you see a similar thing. There's a huge scatter here. And the previous work in this field that showed very strong relationships had denatured the collagen using protease and have shown a nice relationship, but that's a completely degenerated specimen compared to a fairly healthy specimen. If you look in these cases, these were reasonably healthy specimens free of degeneration. You see unfortunately, not a very strong correlation here. So it is a continuing problem in the field to try and understand what non-invasive material properties are of the tissue. This is not the work of our group, but the work of colleagues who are in Christchurch in New Zealand, and these guys have designed a new type of CT scanner, and it's called Spectral CT, or Multi-Energy Spectral CT. Mars is the name of it, Mars Bioimaging. And what this is a multi-energy CT. It uses low dose, and it uses photon counters or photon detectors that are taken from CERN, actually, doing particle physics. And they use the same detectors to count photons, so as an imaging modality, it's very interesting because you can use multiple energies which then can correspond to the different constituents in a tissue. So using this, what they've nicely shown here's some histology of cartilage, and this is showing the GAG content and the nice distribution in GAG content throughout the thickness of the tissue. And what you can do with this is, using an iodine marker, you get an inverse relationship with GAG, and you can get high resolution, 90 micron resolution here of the GAG content. And so the current scanners that they have are reasonably small. You can do small specimens, maybe a wrist. The scan times are equivalent to normal CT, but these guys are now ramping this up, and it's hoped that by 2020 they'll have a scanner that can actually do an in vivo knee joint, for example. And potentially then, I think this is game-changing for the field, to be able to measure the constituents, not only of the cartilage, but also of the bone, and take that information into our models. Okay, I'm not going to dwell on this one too much because a lot of people here know this work, the work that's ongoing with various groups. David Lloyd really pushed this forward, and that's the work that we take kinematics, we take EMG from participants as some sort of surrogate measure of the activation of muscles, and we put all this together and we have some estimates of muscle forces. And again, thanks to BJ and his efforts with the Grand Knee Challenge, because this has provided us a data set of which at least we can get to the point where we can compare the joint contact forces from our estimates here. So we're using OpenSim in our workflow. We take our motion capture markers, reaction forces, we do inverse kinematics, inverse dynamics. We have hill-type muscle models, but colleagues of mine, again at the Auckland Bioengineering Institute, are doing lots of work on continuum representation of muscle. Justin Fernandez, Jeffrey Hansfield are doing some really nice work here to capture the complex architecture of muscles as well, and put that into these kind of workflows. But really what we want to do here, although David and Claudia have done a nice work of making this workflow up until this point real time, the next step is to add the cartilage stress, and we've been doing some work with them on this as well. And our tool for choice here is partial least squares regression, people using neural networks. This is where I think the field of AI, for want of a better term, or machine learning, has a part to play, where we combine the physics-based models, the computational models that we're more comfortable with and that we can test and validate, and we wrap these up in statistical surrogates. And so here, then, ultimately, one idea is that we have our inertial sensors that the subject also wears when they do this various different tasks in the laboratory. They wear their IMUs. We do then a partial least squares on that individual in their lab in a constrained environment, but then we can potentially predict cartilage stress. And we could do this then potentially outside in the real world. That's really our vision here. And that's important because we need to get to total load exposure. So let's talk about this just a little bit. We've been doing some work on a very famous basketball team. You might know of them. They're world famous in New Zealand, the New Zealand Breakers. We're fortunate enough to have 2 years of game data on the Breakers where they've been wearing our sensors. And it's just an example of where you can capture now with wearable sensors a whole lot of data. And this graph, although you don't really need to understand too much about this, I'll orient you. This corresponds to a whole season worth of data for one individual. So that one individual's been wearing our sensors during training and games, and each vertical little strip here is a representation of the impact loads that we determine, and for impact load, we're using the accelerometry data that we get from our individual, left and right, so we can compare left and right limbs for an entire season. And you think, wow, this is a huge amount of data here. And we're providing this as an opportunity then for people to look at altering the load exposure, in this case of basketball players, of athletes. And some work that we have a project now with Irene Davis at Harvard that's sponsored by GE and the NBA, and we're going to be tracking basketballers over time and trying to look at whether we can associate these load metrics with bone health, which is, I think, a nice way to try and potentially validate this method. The other thing we can do with this, and this is some of the work from other colleagues in engineering science as well as at iMeasureU, and this is where you might do some broad classification of different movements. And again, this is not new or novel. There's a lot of people doing this, but imagine you have this entire data set of an individual walking around, and then you can quickly pull out from that data set, these are the time periods in which this person was walking, in which case they were sitting on the couch or doing nothing, they were running or doing all of these various different activities, and then we can predict with certain probabilities what that person was doing over a longer time frame. And then we can run our models maybe on these subsets of data and get much more fine-grained information about what the individual's doing outside the lab. Last but not least, I'll be wrapping up here shortly, is an idea of, this is all great. We can measure some things in the lab. We can potentially measure things outside, and maybe we have some sense of a biomechanical model that brings all this information together. But again, this is a major challenge here. How can we predict, moving forward with a computational model, what kind of damage might occur to the tissue, or can we prescribe some sort of treatment intervention here through changing the mechanical loads in the mechanical environment to alter the tissue state. And so this is some work from Bruce Gardner, who's now at Murdoch University in Western Australia, Dave Smith and his team. And the concept here is that you have some regional stress strain plus load exposure. And I've given you an example of how you might get to that stage. And then you have some sort of other model which is more based around the cellular activity and response of these tissues. So here we have a chondrocyte and its extracellular matrix. We know certain things, of course, about this chondrocyte in its native environment, that it's producing aggregans, collagen, there's a swelling osmotic pressure that's being withheld by the collagen, and of course this is one of the things that we see in early degeneration, a change in those collagen fibers to withstand this osmotic swelling pressure. And all of these things can be brought into a model that looks at consolidation and deformation of the tissue. And this is again some of the work, this is Dave Smith's paper on this with Alan Grodzinski, looking at a tissue level, how might the cells respond to their local mechanical environment. And so here then they can, we can redefine osteoarthritis as a mechanical pathway, and it's a condition in which the extracellular matrix components fail to deliver the required mechanical function under the loads that are experienced. So essentially the loads experienced withstand or supersede those of the strength of the tissue. And so we could then propose that some sort of deformations of the tissue will lead to some extracellular matrix damage and potentially chondrocyte death. And the rate of deformation might alter potentially then joint lubrication and potential wear properties. So Lihai Zhang from the University of Melbourne does work on structural reliability analysis, and this provides an interesting framework in which you can take uncertainty in your model, because we already know that there's variability in the parameters that we measure, there's variability that we have step to step, but you might have then some probability function here that represents the expected loads that you get and load exposure. And of course, this can change. Day to day, we can change potentially what this looks like. And then you also have some sort of predicted resistance. And so here what we're talking about is the resistance or ability of the tissue to withstand load. And so this can be altered by the synthesis rates of the chondrocytes, protease activity that are potentially damaging the tissue, as well as transport and other factors. And so you could have then a model of this and create some sort of snapshot. And the snapshot might look something like this, where in this kind of region here where these two probability functions cross over, you have potential failure. So we know, in this generalized magnitude that the tissue's safe here, given some expected loading, you could potentially damage this tissue. And then you could add this kind of stochastic variability into a model and do some predictions. And this is actually what's been done as just a proof of concept, if you like. And here we're plotting a variable that we're calling tissue health. And this tissue health is then really been described as the strains and the differential in strains from the consolidated state of the tissue. So we're saying under a 35% strain, if you get more strains than that under a kind of unit test load here, you potentially get damage in the tissue. And so across this axis of weeks, what we can see is we have two different opportunities here for altering the tissue state. And these are the opportunities that I presented at the very start. One in which you have a severe, potentially overload. And in the overload case, you might see initially a bump in the response of the tissue. Cartilage responds well to load, so you might have an initial bump here. But then after that, you start to see some changes in the tissue after weeks, which means that potentially the applied load is greater than what the tissue can withstand, and the synthesis of collagen and proteoglycan is then being superseded, and after a period of time, you see then these degeneration. And this is done stochastically, because you can see multiple different paths here, and you can see the mean path that's been plotted by the dark line. And so then after out to 600 weeks, we can see degeneration of the tissue, and anything that's negative here below this red line is showing degeneration of the tissue. So this is kind of a nice framework in which you could potentially bring about personalized modeling to say, if you change the mechanical environment of this tissue, we could predict potentially what that looks like out to a number of years. And here's the other case where we have medium loading to begin with, but then we have reduced load. And we know that our tissues respond more actually to the cessation of load than they do to increased load. And so here we have rapid degeneration of the mechanical properties of the tissue, and we have quick degeneration. And so this gets back to that initial pathway that I showed. There's potential ways in which mechanical loads can influence the degeneration of the tissue. So I'm going to wrap up here with just a few take-home messages. While patient-specific modeling and predictions are really, you could argue they're not quite feasible right now, I think they will be feasible, and they will emerge based on our ability to obtain high-quality patient-specific data. And this is really the focus of what a lot of us are trying to do. And I think validation model sharing is vital to our community, and we'll continue to do that and implore others to do the same. The ability to use larger data sets and use statistical shape modeling offers us some interesting opportunities. And I think mechanistic models of cartilage combined with statistical uncertainty and this kind of structural reliability analysis idea that Bruce Gardner and Dave Smith are doing, I think gives us a really interesting and useful framework in which we can take this field forward and do predictions on a personalized nature. So with that, I'd like to thank my colleagues and co-authors. There's lots of people involved in this, of course, and some of my funding sources, and thank you very much for your attention.